Very good evening, respected IAP President, Kozhikode President Dr. Sindhu, Dr. Sushma Madam, Dr. Srinivasan Sir, Dr. Purushottam Sir, all my seniors, my dear students. Sir. So I'm very happy to see that our program is going very strongly and very punctually without any interruption. And also we are getting more and more students. I request all the HODs of medical colleges to come forward because otherwise it may be sometimes it is difficult to get cases under this one. So in rotation, I think we got now enough medical colleges all over Kerala. So I think I request all the HODs to prepare their students for case presentation and preparation. And also I wish the program all the best, all success. Jai Hind, Jai IAP.
Sushma Madam, Madam, please give some comments regarding this. Any advice to our juniors?
Madam.
Sushma Madam.
I did not hear what is it.
Madam, some comments to the juniors from your side, Madam, regarding this program.
So let me see.
Okay, Madam. Srinivasan sir is always there with us for this program. Sir.
He's there.
Okay, then we will start the program without.
Yeah. At the end, we'll have discussion because last time, so Swam also participated in discussion a lot. So at the end of the case presentation, we'll invite all of them.
Hello. ഞാൻ പറയുന്നത് കേൾക്കാമോ? ഞാൻ കുറെ നേരം എനിക്കൊന്നും കേൾക്കുന്നുണ്ടായിരുന്നില്ല. ഇന്ന് നമുക്ക് ആകെ ഒരു കൺഫ്യൂഷൻ ഉള്ള ദിവസമായിരുന്നു. ബിക്കോസ് കാലിക്കറ്റ് വേറൊരു ഇത് പ്ലാൻ ചെയ്തായിരുന്നു. പക്ഷെ ഞങ്ങളുടെ ഒരു ഫാക്കൽറ്റിയുടെ സെൻഡ് ഓഫ് മീറ്റിംഗ് ഉള്ളത് കൊണ്ട് ഞങ്ങൾക്ക് ലാസ്റ്റ് മിനിറ്റിൽ അത് ക്യാൻസൽ ചെയ്യേണ്ടി വന്നു. അപ്പോ പുരുഷോത്തമൻ സാറ് ഇന്നത് ചെയ്യാന്ന് പറഞ്ഞതുകൊണ്ട് മാത്രമാണ് ഇന്നത് പോസിബിൾ ആയത്. അപ്പൊ അതിന് പുരുഷോത്തമൻ സാറിന് പ്രത്യേകം നന്ദി പറയേണ്ടതുണ്ട്. ലാസ്റ്റ് മിനിറ്റിൽ ഡിസ്കസ് ചെയ്യാന്ന് ഏറ്റതില്. അതുപോലെ തന്നെ ഇമ്പോർട്ടന്റ് ആണ് ഇന്ന് കേസ് പ്രസന്റ് ചെയ്യുന്ന ഡോക്ടർ സന ഹംസ. സന ഹംസയോട് ഇന്നലെ ജസ്റ്റ് പറഞ്ഞിട്ടേ ഉള്ളൂ. സന ഹംസ ഒരു പേഷ്യന്റിന്റെ വീട്ടിൽ പോയി അവിടുന്ന് കേസൊക്കെ എടുത്തിട്ടാണ് ഇപ്പോൾ പ്രസന്റ് ചെയ്യുന്നത്. സോ ഷി ഓൾസോ നീഡ്സ് എ ബിഗ് റൗണ്ട് ഓഫ് അപ്ലോസ്. അപ്പോ ദാറ്റ് ഇസ് വാട്ട്. സോ I am very happy to know that there are so many postgraduate students who are taking this very seriously and taking lot of effort to make this happen. That's all. So I'd like to hand over to Purushottam sir.
Good evening. As Mohandas said, Sana needs appreciation because she came up with the case yesterday only. And there was no time for preparation for both of us. So actually, it's a developmental delay case. We discussed the similar case 2 months back. So if you go on repeating that, that will be boring. So my basic idea is to hear the case from Sana. I need comments from Sushma Madam, Srinivasan Sir, Dr. Virendran, and senior persons. In the initial half an hour, not me. I won't be too much discussing. And maybe in the second half, exclusively for the postgraduates for exam purpose, I'll be talking about the case management. So this day is for the seniors. I'll be once in a while commenting. So Sana, start. Otherwise, it will be boring because it is a very same case. I don't have too much of this thing. Repetition is not needed. Maybe the seniors' comments are more important in the first 30 minutes. Okay, Sana, just start.
Thank you, sir. Good evening, one and all.
Sound is a little, maybe you can keep it near.
Sir, now is it clear, sir?
Right.
Sir, I'll share the slides. Am I visible, sir?
Yes.
Okay. Good evening, everybody. Today I am presenting Khadija, 6-year, 8-month-old girl residing in Vellimadukunnu, Kozhikode. Informant being mother is reliable. Presented with chief complaint of delay in attaining age-appropriate milestone noticed since infancy. Since it's a case of developmental delay, I would like to start with antenatal history. Mother married at 20 years of age. This is the third child of a non-consanguineous parentage, spontaneous conception, born to a 38-year-old mother and 48-year-old father, had regular antenatal checkups. There was no history of fever with rash, bleeding, PV, radiation exposure, or chronic drug intake during the first trimester. No history of urinary tract infection. USG done were reassuring. Quickening was appreciated at 5th month of age, and there was no history of increase.
Mute all the participants. Mohandasan, mute.
Hello.
Unmute Sana. Sana, can you talk?
May I continue, sir?
Yeah, continue.
Iron and folic acid and calcium tablets were taken. UST taken at 5th month was normal. At 7th month, she was detected to have gestational hypertension and took oral medication, and at the same time had gestational diabetes mellitus and was on dietary modification. UST done were normal. Gestational hypertension was persisting even at 9th month of age and was continued on oral medication. There was no history of bleeding PV or leaking PV. She got admitted in view of high BP. And also, there was no history of increased or decreased LICA and no history of foul spelling LICA or fever at the time of delivery. When in natal and postnatal history, she delivered by a term emergency cesarean section. There was no history of prolonged labor. Indication was meconium state amniotic fluid and fetal distress. Birth weight was 2.8 kg. Baby did not cry soon after birth and needed resuscitation. She was admitted in NICU in view of respiratory distress soon after birth, developed seizure on the neonatal day 1 as informed by the doctor. Child remained sleepy throughout the day. She noticed to have decreased spontaneous activity. She was on oxygen support for 2 days, weaned off later. She was on IV fluid for initial 2 days, and express breastfeeding started on neonatal day 2 via tube feeding. On day 5, started on parallel feeding. Child had to wake up the baby for feeding. When put on breast, there was no sucking and difficulty in latching was present. There was no history of bluish discoloration or vomiting, no history of jaundice. On neonatal day 15, baby got discharged, and she was on parallel feeding and was on continuous oral medication, and there was history of poor activity which was persisting. After discharge, at home, the baby had poor activity and noticed to have a stiffening of the body while handling the baby. There was scissoring of lower limbs and there was difficulty in changing diapers. When attempted feeding, tongue thrusting was also present. There is history of multiple episodes of choking while feeding and history of nasal regurgitation of feed present. Drooling of saliva was also present. On neonatal day 40, baby developed incessant cry, which lasted for about 1 hour, which was inconsolable. Such episode was present for 2 to 3 days. Developed sudden spasm of, after which the baby developed sudden spasm of upper limbs and body, which lasts for about 10 to 15, which lasted for a few seconds, around 10 to 15 episodes in 2 minutes, followed by a cry. There was similar episodes around 2 to 3 times per day. Baby was evaluated and was admitted and started on anti-epileptic medication. Which then the episodes gradually reduced, and by 8 months of age, she was free of these episodes. Mother noticed that child did not attain head control and was not recognizing mother. She was started on physiotherapy at 9 months of age. After physiotherapy, she started attaining milestones slowly and stiffness of body decreased. Neck control was partially attained till now, which was secured at around 2.5 years of age and rolling over by around 3 years of age. Baby was keeping her hand open by around 1 year of age, and there is momentarily holding of objects. Before that, there was a strong grasp of the hand that was present. Now she looks at mother's face, which was attained at around 2 years of age, and she responds to call when called by her name which was attained at around 3 years of age. She is making only cooing sounds, which was attained at around 3 years of age. There was history of skipping of medication because of the corona pandemic for about 1 year. Later, at 3 years of age, child developed tonic-clonic movement of both upper limb and lower limb, which lasted for about 1 hour, associated with frothing from mouth, for which the child was evaluated. She was admitted and evaluated. After which similar episodes happened for about 4 times. Each episode lasted for less than 5 minutes. This happened around 3.5 years of age. Later, last episodes of seizure occurred around 8 months back. That episode lasted for more than 1 hour, and child was started on a new medication and is seizure-free since then. She is confined to bed and needs support for daily activities. History of visual impairment and abnormal eye positioning is present. History of recurrent respiratory tract infection, around 3 episodes in the last 6 months is present. There is no history of drooping of eyelid, no facial deviation, eye closure is normal, no early hand preference, no urinary retention or constipation. There is no bed sore, fracture or skin infection or history of urinary infection. There is no history of sleep disturbance or altered behavior. History of dry by candidation and can appreciate hot and cold water while bathing. Can I continue, sir?
Yes.
When we come into developmental history, gross motor, as we have already explained, developmental quotient corresponds around to 6.25%. Gross motor development. Fine motor developmental quotient is around 3.75%. Social and adaptive is around 7.5%, and language is around 3.7%. Vision and hearing, there is perception of light present, and global development delay is present with an development quotient of 5.3%. When we come into immunization history, she is partially immunized till 9 months of age. BCG scar is present, no optional vaccination taken, and no adverse event following immunization. Dietary history, mother fed the baby with express breastfeeding and formula feeding till 6 months of age, started complementary feeding with ragi at 6 months. Now is giving smashed food. There is history of frequent aspiration of feed, and there is no chewing and drooling is present. Required calorie is 1,350 and protein is 20 gram, and there is a deficit of 700 kilocalorie and 11 gram of protein. When we come into family history, there is a history of behavioral change in elder sibling at around 14 years of age. She is a female child, diagnosed as depression and is on treatment. There is no history of seizure disorder or unexplained death in the family members. When we come into socioeconomic status, this is a 5-membered family. Father studied up to 10th standard as auto driver. Mother is a homemaker, belonged to lower middle class according to modified Kuppiswamy scale. She is getting disability pension. There is no house modification that is done. Physiotherapy center is around 2 kilometers from home, and they are attending physiotherapy and speech therapy daily and occupational therapy occasionally. And the teacher is coming home for teaching the child every Wednesdays. Summarizing the case. This is a case of 6 year, 8-month-old girl, third child of non-consanguineous parentage, not fully immunized to up to age, with history of gestational hypertension and diabetes in mother, with baby born appropriate for gestational age, with history suggestive of perinatal asphyxia as evidenced by the meconium staining amniotic fluid, presented with global developmental delay, seizure and feeding difficulty, with features of stiffening of limbs and visual impairment.
At the end of the history, Sushma Madam, Srinivas, anything you would like to discuss more further? Madam, just your comments, madam.
See, can you show me the family tree once more? So the eldest one is 22 years.
Yes, ma'am. Elder one is 22
I
years.
couldn't follow what you said about the middle one.
Elder one only, I explained about the elder one, ma'am. She was normal till 14 years of age. At 14 years of age, when she was in 9th standard, she developed behavioral changes. She became less talkative, less interactive with the surrounding, and she's diagnosed as having depression, ma'am.
आपने कॉल किया था NIC बोला था सर आपको किया था
Presently, how is she?
डॉक्टर से बात किया था
Sorry, ma'am.
At present, how is the eldest?
She is presently having the symptoms, ma'am. She is not completely free of symptoms. She is behaving normally at times, but abnormal behavior is also there, ma'am.
इधर ही आएंगे ना सर
Nothing else I had to ask.
Anything more? Anything more, madam? Swati, please mute your mic. Okay. I just don't want to discuss the entire story. So from the at the end of the history, what is the
ना बस को बिठा अरे तो लैट्रिन में पानी हम धो देबे हम साफ करें तो ओकरा पे बिठा दे चल जो
That's a mute it, le.
ഞാൻ ഹോസ്റ്റ് അല്ല. ലതിക ഒന്ന് എല്ലാവരും മ്യൂട്ട് ചെയ്തിട്ടേ.
അത് എങ്ങനെ മ്യൂട്ട് ചെയ്യണ്ടത് ഞാൻ നോക്കുമായിരുന്നു.
അതെ, മ്യൂട്ട് ഓൾ എന്നുള്ളൊരു
മ്യൂട്ടപ്പോൺ എൻട്രി ആണോ? മ്യൂട്ടപ്പോൺ എൻട്രി എന്ന് പറഞ്ഞതാണോ ഞെക്കണ്ടേ?
അല്ല മ്യൂട്ട് ഓൾ എന്നുള്ള, അതായത് നമ്മള് പാർട്ടിസിപ്പൻസിന്റെ ലിസ്റ്റ് കിട്ടുന്ന സമയത്തെ അതില് മ്യൂട്ട് ഓൾ.
ഓക്കെ ചെയ്തിട്ടുണ്ട് സർ. കണ്ടിന്യൂ.
എനിക്കൊന്ന് മോഹൻദാസ് സാറിനെ കോഹോസ്റ്റ് ആക്കി കൊടുക്കുക, അപ്പൊ ശരിയാവും.
Okay. At the end of the history, Sana, what do you think? This is a case of delay. Mute ചെയ്തിട്ടില്ലേ എല്ലാരും ഒന്ന്? Okay. What at the end of the history, it's a delay. Are we missing a situation of a regression? What type of delay it is, Sana?
Sir, this is a case of developmental delay, sir. In the history, there is no history of regression of milestone that is already achieved. There is a delay.
That's a question Madam was raising. Whenever you get a case of a delay, always doubly cautious you should be. Am I missing something other than this thing? Like, especially when there's a family history of an elder sibling having some problem, we need to consider the possibility, are we missing something? Cerebral palsy mimics.
Yes, sir.
So you need to go in depth about the family history, the elder siblings case, but that doesn't seem to be fitting. Up to 14 years, that child was all right. Then only psychological problem, and she is after 8 years also she having that depression, psychiatric problem only. Very unlikely that this is related to this kid's problem, which started early newborn period onwards, with a more of a all the motor fields, everything is affected. So unlikely to have some relation. The other question is there any other clue for another CP mimic? Especially if there is no perinatal, antenatal insult or a disproportionately severe delay. In this case, there is a significant prenatal insult, and definitely overall pattern is global delay. So in the evaluation development history, there is some small points. When will you call it a global delay?
When there is involvement of more than 2 domains, sir. And
Two domains. Out of these 2 domains, what exactly?
Gross motor and fine motor should be considered as one domain.
One domain. Okay. Gross motor and fine motor, one domain. And the other, in this case, definitely no doubt, it's a global delay. And in your presentation, it seems 3.3, 4.5. That is a little bit of, there's no need for that. So almost significant delay. Development caution in all the fields are very severely affected. Okay, so don't go in depth about this thing. You just finish off the binding words.
Okay, sir. Let me continue, sir.
Yeah, continue.
On the general examination, it is seen that child is alert, lying over the bed, upper limb flexed at elbow and lower limb left extended and kept crossed, feet plantar flexed, knee and ankle contractures are present. No pallor, icterus cyanosis, clubbing or lymphadenopathy.
One point here. So for the examination thing, we'll be getting maybe 45 minutes for postgraduates. So here the first start of the examination. You may get any sort of a case, maybe walking to, maybe totally bedridden. There are your inspection, first moment how the child is. When you're coming, walking to you, what is the gait and expression, the speech, everything. So examination, assessment start the moment you see the patient. Here it's a bedridden patient. There again the examination starts. So here the attitude and posture description is important. So what is something striking in this case? The position of the hip. So when you are getting a spasm, that may be misleading, but in this position, the hips are little abducted. Of course, the foot position is plantar flexed, but a little bit unusual to see this sort of an abducted position. Any child walking towards you also is very important. How he is walking. Is a wide-based gait is very unusual for a CP child. So nowadays, the atonic and the cerebellar type of this is going out. Later, the recent the classifications, the hypotonic CP is out, and the cerebellar things also. So wide-based gait a bit unusual for a CP, and this position also a bit unusual. Of course, in the next video, it will be more clear. Go forward.
Okay, sir. Thank you, sir. This is the image of a child held in ventral suspension.
Now it is clear because you see the position. There is a scissoring is obvious. So there is a spasm in this position. And here also you look from above downward was the position of the upper limb, the fingers, the hands, everything. You should be, the inspection should be obvious. Okay, go forward.
Vitals were within normal limits. Pulse rate was 92, regular normal volume and character. All peripheral pulses were equally palpated and no radiofemoral delay was
So what's the importance of this slide? In an examination, you will be answering, is there any emergency now? In an examination case, this won't be relevant because a patient will be stabilized by the time it is given for examination. In the usual casualty and all, definitely, these are all important. They may be coming with an aspiration pneumonia or a seizure or something. All these have become important. Other cases, examination, this may not be that much relevant for you. Okay.
On head-to-foot examination, head appears small. There is no ridging of sutures. Synovitis is present. Eyes squint is present. There is no corneal opacity, conjunctival cirrhosis or Bettard spot. No subconjunctival hemorrhage present. Lossets ear. Oral cavity, tongue thrusting movements are present. Drooling of saliva is present and caries teeth is present. There is no chiritis or gums are normal. Chest wall appears normal and abdomen appears normal. Limbs contracture present at elbow, knee and ankle joint. No wrist widening or no fracture or dislocation. No bed sores. Nails appears normal. External genitalia appears normal. No neurocutaneous markers. Spine, there is no scoliosis. No diaper rash or no signs of neglect. Anthropometry, weight for age is less than 3rd centile. Height for age is less than 3rd centile. BMI is less than 3rd centile. And head circumference expected is 47, 51 and measured is 47. When we come into developmental assessment, gross motor, when pulled to sit, there is mild head lag present, and on putting to prone position, able to lift head above couch, corresponding to 5%. Fine motor, hands are open, momentarily grasp was present. And language, only cooing was present. Social adaptive, recognizes mother and social smile is present. Vision, child is not fixing and following object completely. Menace reflex is present. Hearing appears normal, having global developmental delay. When we come into nervous system examination, child is alert, less interested in surrounding, comfortable with mother. Cranial nerve 1 not able to elicit. 2 menace reflex is present. Fundus appears normal. There is no ptosis. Left divergent squint is present. Extra ocular movement are bilateral equal and full. Light reflex as direct and concentric right reflex is present. Accommodation not tested. No deviation of angle of jaw. Jaw jerk was normal and conjunctival reflex was present. Motor, no facial asymmetry. Able to close both eyes. Nasolabial fold on both sides are symmetrical and taste able to perceive. Hearing, child is alert to sound. Uvula is central. Palatal movements are normal and equal bilateral. Gag reflex is exaggerated. There is turning of neck to both sides. Against force could not be tested. Dystonia of tongue is present. There is no tongue atrophy or fasciculation. No deviation and protrusion of tongue. When we come into motor system, bulk is comparable on both sides. Tone is increased in both upper and lower limb and spasticity in both upper limb and lower limb present. Angles are popliteal 70, adductor 50, dorsiflexion angle 40, and scarps and could not close the midline. When we come into muscle power, neck flexors and extensors about grade 3, upper limb shoulder grade 3, elbow grade 3, trunk and paraspinal grade 2, hip, knee and ankle grade 3. Superficial reflexes, conjunctival is present, abdominal reflex was absent, and plantar is extensor. All other deep tendon reflex, biceps, triceps, supinator, knee, and ankle jerk was exaggerated. Jaw jerk was normal, and there was no clonus. Primitive reflexes were absent. And there was no involuntary movement. Cerebellar signs could not be tested. Sensory touch and pain sensation were present. Bowel and bladder control not attained. No signs of autonomic disturbance. Skull and spine appears normal, and no signs of miniature irritation. Respiratory system, trachea was central, chest movement was bilaterally equal, and normal vesicular breath sound was present, and there was no adventitious sound. Gastrointestinal system also was normal. There was no distended or dilated veins, all quadrants moving equally with respiration. And there was no organomegaly, bowel sounds present, and hernial orifices were normal. JVF was not elevated, apex was in the midline, the fifth intercostal space. There was no murmur, and insulin was normal. On summarizing, we have got a 6-year, 8-month-old girl, third child of non-consanguineous parentage, not fully immunized up to age, with history of gestational hypertension and diabetes in mother, with baby born appropriate for gestational age, with history suggestive of perinatal asphyxia as evidenced by meconium staining amniotic fluid, presented with global developmental delay, seizure and feeding difficulty, with features of stiffening of limbs and visual impairment. On examination, significant finding of microcephaly, wasting and stunting, spasticity with exaggerated deep tendon reflexes and extensor planta was present with contracture, and there was no clonus and features suggesting of pseudobulbar palsy. On diagnosing, it's a case of static encephalopathy, mostly cerebral palsy, which is quadriplegic type. Most probable etiology is perinatal asphyxia with global developmental delay and pseudobulbar palsy associated with GTCS, visual impairment and squint. Functional classification 5, a child is partially immunized.
Okay, you stop the sharing. Susuma madam, Srinivas sir, your comments, because I don't want to repeat the same thing. Those who
no, I think she has presented well. I think she can think of this thing, possible diagnosis from the history. Then subsequently she can tell the exam findings and tell what is happening. Full. So it's very nicely presented. Yeah. And as you have correctly mentioned, the previous child who is now past adolescence, and so that's a different story, and this is a different story. So I think she can proceed with this thing. You can ask some other person to give the comments.
Susuma madam, your comments.
Well, contrary to the opinion already got, I think she should have presented in a little bit space in between. Because you have grasped everything, others have to follow you. Isn't it? Then you said, how did you measure the length of the child? You have brought here that there are contractures, and you have committed that the length is 111 centimeters. No other comment. Do you think that was a correct length measurement, or did you make any other adjustment in measuring the length of the child? What will be the type of length measurement when there are contractures or some other problem in some part of the body? The linear measurement will be somewhat abnormal when there are contractures. Did you make any other adjustment or any other method? It's a simple question.
I measured part by part, ma'am.
Loud.
I measured in baby was lying in the bed, ma'am. I measured part by part.
I
Measured part by part.
Segments.
They measured part and plus added everything and said the
that is the segmental measurement.
Yes, ma'am.
That you should know. I did the second. You should have projected that simple measurement.
Okay.
That is 111 centimeter. I don't think that is a complete. That's a fully normal because of the contractures. I couldn't stretch the child completely, so that I had to make the segmental. Did you do the segmental measurement or not?
Segmental measurement I have done.
Then
ma'am.
why didn't you highlight that? It's a very simple, but a gross mistake.
Okay.
Then another thing you said is that the child is having pseudobulbar palsy. What are the clinical features of pseudobulbar palsy? To highlight which all clinical features you got. You said the jaw jerk is normal or absent.
Yes, ma'am. Ideally, in pseudobulbar palsy, jaw jerk should have been present, ma'am. And upper motor neuron, the associated with spasticity, gag reflex is exaggerated. In our case, gag reflex is exaggerated, ma'am. In bulbar palsy, gag reflex will be absent, ma'am.
See, if you say even though the jaw jerk is absent, these are all the other features by which I commit that there is pseudobulbar palsy. The points you did not highlight.
Okay.
So what will be the problem if the child is having pseudobulbar palsy?
Child will be having.
Does it produce any problem to the child?
Yes, ma'am. A child is having difficulty in swallowing food. There is regurgitation of feed that is present, ma'am, and there is drooling of saliva that is present. And feeding difficulty is there, ma'am. And
what difficulty? What will develop to the child?
Aspiration can happen, ma'am.
You did not bring it because that will lead to the death of the child, isn't it?
Yes, ma'am.
One is that the child will be having swallowing difficulty because of the spasm. Second is that if it goes into aspiration, immediately the child will be asphyxiated and death may occur.
Yes, ma'am.
It's not something to just giving as a passing comment.
Okay.
When there is pseudobulbar palsy, it is something serious. The mother will find it very difficult, or the bystanders will find it very difficult to feed the babies.
Feeding is difficult.
And you said tongue is normal. When there is pseudobulbar palsy, tongue will be normal. When the picture itself, it is a spastic tongue.
Yes, ma'am.
Okay.
Thank you.
Madam Parvati, madam is the. Madam, your comments, madam? Madam is not there. Virendra Kumar?
Yes, sir. Yes, sir. It's well presented. My doubt, what the head circumference she has not mentioned. Head circumference. Because if the head circumference is too small, there may be an addition of antenatal cause in addition to the perinatal cause. Because the perinatal cause, the child is discharged by day 14. The present symptoms are little out of proportion to the perinatal event. Yes, there is a significant perinatal event, but the present symptoms are little out of proportion to the perinatal event. And the maternal age and paternal age at the time of delivery is a little advanced. 38-year maternal, 45, 46 paternal age. So there is an antenatal plus a perinatal and some low set years and some other dysmorphic features are also there in the description. Sinophrys and Losettes, she mentioned in the list also. So head, if it is too small, maybe antenatal also. There is an antenatal insult also. And also in the final summary, the gross motor function scale, manual ability scoring, IDAX, eating and drinking ability scale, that also can be added. That much, sir.
Okay. Any other comments from anybody?
Head circumference is 47, sir, and expected is 51. When we compare to at the age of 5 years, it is below third sentence, sir.
Any comments more? Anybody else? In the tongue examination, did you say dystonia of the tongue? What is that?
It is past the sir.
Better don't confuse, because you need to, when you get a case in an examination, 40 minutes examination, I said the examination starts at the moment you see the child. Make use of the examination, developmental assessment, your history taking. During your history taking, you are assessing the development, the way child is behaving with the mother, what the baby is doing, and you should be giving some toys or pencils or whatever, and you're simultaneously doing the assessment, because the very short period of time, you should be able to do everything together. So the different scenarios, in this case and the previous discussed case, it was a very severe situation, bedridden patient. There again, in the assessment, you are systematically going to answer different questions. First question, you answered already from the history. Is there a delay? What type of delay? What is the severity of delay? Is it a regression? What is the pattern? All these things you have answered from the history, because history only can say there is a regression, because your assessment is just like a still photograph. What is the present status? You may not be knowing whether it is a regression. So that much is the importance in the history. In the examination, in this case, you need to answer 1, 2, 3, 4, 5, 6 questions. First thing is the anatomical type, then the physiological, then the functional, then the other systems involved, maybe visual. So stepwise you're answering. In this case, so first question you answered already from the history. There is a significant delay. It's not pattern of a regression. In this case, delay is very significant, and that is proportionately in all the fields. It's not a sparing of one field, the other. Every field is equally involved. Significant or less than 10 is the DQ in all the fields. In that situation, second question is, what is the reason for the static disorder?
Hello?
Yes. Anybody want to comment? In this case, developmental delay, static disorder. In the static disorder, in the examination, you need to answer what is the basic situation. Is it suggestive of a CP itself or some other conditions like genetic problems can be there, some of the intrauterine infections can be there, few of the other situations where the classical definition of the CP is not answered. So what exactly is the CP? And in this case, is this CP? So is this CP, and what are your points for your argument that this is a cerebral palsy? You said a static disorder, cerebral palsy. How can you justify that it is a CP?
It is a static encephalopathy with a disorder of movement and posture, and there is a insult. There is a disorder in movement and posture causing activity limitation is also there, and there is a insult that is happened during the developing fetal or infant brain. Here, perinatal asphyxia is there. It must have caused a hypoxic insult to the fetus, and that is the result of this involvement of the brains.
It's a problem, motor, posture and movement disorder, non-progressive, due to an insult. So all these criteria are satisfied, associated with other things also, like seizures, other things are also there. So definitely it is fitting with CP. CP mimics you considered and excluded. So next question is, what is the type of CP? Anatomically, what type of CP?
There are, when we consider, there is spastic CP. Spastic can be diplegic or quadriplegic. Then we have
that is the physiological classification, anatomic classification. Okay, that you are telling the physiological thing. It's a spastic
quadriplegic.
Spastic quadriplegia. So that is
if dystonia was there, she has mentioned, I think it must be mixed. So
it's important.
Yeah.
Sir has brought up a different point, because why are you assessing all these questions? Because you are planning for the management. Each and everything what you are not doing is not for passing examination. Even when you come out of this examination, all these points you are answering is basically meant for your planning, what you can do. So in this case, sir said, I am classifying it as a spastic CP. The selective methods for that is different when there is an extrapyramidal element. So you need to answer whether when the tone is high, is it a spasticity only or spasticity with rigidity or any extrapyramidal element? So you yourself mentioned in some area there is some dystonia and all. So the question in this case, in the first three things, topographically, definitely in all the four limbs are involved. There again, is there a disparity between the upper and lower limb? Is there a disparity between the two sides? And is there a lower bulbar involvement? So that is the topographical answer. So according to you, there is a pseudobulbar palsy also, but that is not convincing, as madam was asking. In a patient with pseudobulbar palsy, the feeding difficulty will be significant and there will be drooling. Oromotor dyskinesia elements, you need to be establishing, because you need to address that part for the management. So it's not merely enough to say that pseudobulbar palsy is there. So it's not the jerk only. Okay, of course, the jerk is important. Apart from that, drooling always, because there is an incoordination of the feeding. In this case, you didn't mention about the drooling. So drooling will be there in a case of pseudobulbar palsy. So that is very important. The assessment is important, then only you can plan. Okay. So there is all four limbs involved, upper, less and lower more, or equally all. According to you, it's all equally involved. There is no asymmetry also.
There is no asymmetry, sir.
So topography, anatomically, it is all the four, but the pseudobulbar palsy part is a little bit doubtful. The next question Srinivas pointed out, is it a spasticity only, spasticity plus rigidity? How will you differentiate? How will you answer?
How to differentiate spasticity and rigidity, sir? In case of spasticity, we have to move the limb fast movement, whereas in case of rigidity, there is change in case of fast movement as well as in slow movement. In spasticity, there will be in rigidity, there are two types of rigidity. There can be class 9
two types, it's immaterial for the management. Is there an extrapyramidal thing or not is enough? Okay. You need not differentiate lead pipe, cog wheel and all. Answer is between whether there is rigidity or extrapyramidal sign. All that's all.
There is spasticity.
Velocity dependent, but that's what you said. Okay. Spasticity is velocity dependent, other is not. And what are the other points, sir?
To differentiate spasticity and rigidity, sir.
Right. The variation with the time. More in case of extrapyramidal. Okay. And one more thing.
Dystonia will be absent in sleep, sir.
If it's a dystonia, it will be rotatory position.
Rotatory positioning, and it will be absent in sleep.
Rotatory position will be there in the dystonia situation. The variation between the time will be the more in case of an extrapyramidal. And one limb when you are lifting, there's a possibility of a cross movement in the other. And what happens in the sleep? So all these are points. Okay, all these are points to differentiate and to tell that there is an element of extrapolation.
Dystonia.
There is an abnormal movement, of course, no doubt.
Mm.
The dystonia is one of the commonest things.
Mm.
And the other things you need to check. Is it a velocity dependent only or the other things? Because management is important in this case. So in this case, the physiological classification according to is this spastic type of quadriplegia a doubtful pseudobulbar palsy? And then comes your third question. In this case, what is the functional grading? Dr.
Grade 5.
was pinpointing to that. Okay.
Grade 5, sir.
Functional grading.
Grade 5, sir. Baby is child is bedridden. Grade 5.
No, it's not enough. The answer is incomplete.
GMFS grade 5.
GMFS. That is a gross motor part.
Functional classification.
Its grading is 5. The worst of the situation. What about the other grading? What are the other things to be graded? Because you're going to plan how much support I can give. What is the prognosis? A lot of questions some others are asking will be to be answered. Okay. A lot of questions. Whether my child will walk. Scientifically, you should be able to answer those questions. Okay.
Child has
A
not.
7-year-old child now with a GMFS 5. What is the chance that taking into consideration that what is the chance that the baby is walking later? Parents will be optimistic. Will it be possible?
Less likely, sir, because if the child is able to sit at the age of 2 years, we can expect the child will walk. If the child is not able to sit at 4 years, the child is less likely to walk at 7 years of age.
GMFS and what are the other things, functional assessment?
Others.
Manual ability scale. So what about the manipulation skill of the baby? That is again, there is a score. So that you need to tell. And what is the third thing to be assessed? What is the third thing? You said communication.
Communication.
Speech and communication. Okay. In this case, what is the grade? Manual ability scale is again worse. Only thing is that a baby can keep the hands open. There is no
hands open.
There is no cortical twisting or the finger is not there.
Not there, sir.
Maybe may not be 5. Definitely significant. Child is only holding what the
momentarily, sir. Momentary hold is there.
Be 5, a little lower than that. So manual ability scale need to be utilized for what you can do. How much of occupational therapist can help her for the day-to-day activities? Because your fingers and thumbs are the one thing which are needed for your day-to-day life. For holding the spoon, for taking something to the mouth, for handwriting. Okay. So how much you can train with the use of the occupational therapists. So manual ability scale scoring is important. It's not 5, maybe definitely it's less. What about the communication here? That is again
only cooing, sir.
Okay, so that also very bad. That scaling is important. And what is the last one? That is EDAC. See, eating, drinking. So that is the one thing. It's very important when you're telling that there is a pseudobulbar palsy. In that situation, that scale also will be on the lower side. So that is the third thing. How much is the functional affection in my child? Because the prognostication and planning is based on this functional assessment. Okay.
Okay, sir.
Okay, in this case, the parent's question is, what is the chance of walking is decided by 2-3 things. Like you said, what are the 2-3 things? A child who is able to sit by 2, very likely that in this case, it's not possible. Second thing, 2 more points you need to consider in every CPs. What is the status of the primitive reflexes? Okay. So what is the importance of the primitive reflex and the positional reflexes? It's not a reflex. Okay.
When the primitive reflex regress only, the normal development happens. When
So
the asymmetric
what is the criteria for the prognostication?
Criteria, I don't know, sir.
If the more than 3 of these primitive reflexes are persisting, chance of walking is minimal in a young child. In this case, you said 1 primitive reflex is still persisting at 7. glabellar tap is persisting. That's what you said. Okay. Not the routing, sucking, the other thing. The other two, what about the positional, this thing? What other thing?
Asymmetric tonic neck reflex is not there.
Parachute reflex and writing reflex when the patient is, okay, all these things should be developing. So prognostication is based on the presence of the neonate, these reflexes and the coming of these position reflex. That is used for the prognostication. The other thing is GMFS scale in the younger child is very likely to advance, but in a 7-year-old child is still having grade 5, it's very, very unlikely that improvement. So in this case, when the mother or parents are asking, the very, very gloomy prognosis for the walking or anything. Okay, so that is a functional thing. And the last part in the assessment is the comorbidities assessment. Okay, so how will you assess the comorbidities? The whatever position you are getting the child, you need to assess how much of the deformities has occurred. Actually, that's not the comorbidity. The deformities occurred due to this thing. So in a sequential manner, what you need to consider when the UMN is involved, what will happen? There will be agonist muscle. The one group will be more spastic. The spasm in the initial stage, the newborn period onwards, the initial weeks you learn all these things. What will happen? The spastic will lead on to changing the position of the joints. So at that time, it is only soft tissue. Later, the soft tissue with the position will get shortened the tendons and the ligaments. Later, it will lead on to deformities, including the bones. So what you're assessing is what type of the deformity has occurred already now. So the level of intervention, the bringing in of the specialist as a multidisciplinary and all depends upon this assessment is the fourth group. How much is the other deformities which has occurred? In what situation? The last of the situation, the bone also is deformed. The hip is dislocated. The scoliosis is there. That led on to GER. All those things needs the orthopedicians and the neurosurgeons involvement. A little less only the surgery and releasing of the general surgeon is enough. And even earlier, all your the spasm releasing and the orthosis and all. So your level of care is decided by the fourth assessment. How much is the deformity as a sequelae which happen in different areas, in the hip, in the spine, in the limbs. So that is by different thing. The moment the patient is coming, walking to you, that is the evident from the deformity, the crouch gait, the jump gait. All these things indicate what? The spasm is significant enough to produce the deformities at the hip and knee and the foot. So that is how you are assessing that. That is the fourth thing. And the last assessment is other complications. This is important. How much of the nutritional problems are there in this child? Are there respiratory complications? How much of the seizure thing is there? What about the intellectual disability? What about the visual? What about the hearing problems? Sleep pattern? Okay, the bowel disturbances, constipation, the caries to the secondary infections, infestations, all these need to be assessed. The clue is there in the general examination, head to foot. Lot of clues are there. Systematically, you need to assess. Answering everything, nutritional problem, micronutrient deficiency problems, so the infestations, infections, and the neglect part, all these things. So you make use of the general examination. So systematically, this is how you will be assessing for the planning. So any comments from Srinivasan sir?
No comment. You have discussed so extensively each and every point, and Dr. Sushma Bhai also has given her inputs especially Georgia case. She has mentioned the importance of it, and drooling, you have mentioned. Even normal people, they drool when they are lying down, and it's a very important problem for these type of children, no? Yeah, they give some medication also sometimes. It's so distressing, and then there will be rashes. You have stressed all the important points very well, sir. Thank you. I also learned a lot. I am here mostly as a student. Then, okay.
Thank you, sir. That's for the compliments. What about Sana? So what are your, suppose the parents ask you, what are your plans for the child? What about the prognosis? And what is the main point which that stops you, which main hurdle in these cases?
First, we have to diagnose that this is a case of cerebral palsy from proper history and examination, and by scoring system, we can find out the severity. Then we can find out the etiology of
Not we can. What is this status of this patient? You tell.
This
what are you going to do for this patient? What are you going to talk to the patient? Counseling. What all things will you include?
The treatment of cerebral palsy is always multidisciplinary. We have to
talk about this patient. What decides the prognosis of this patient? Before you invite the who all will be invited, before that you should have an idea as the main team leader. Okay, what's your idea? What is the chance of this baby having a normal baby?
This child is having problem, associated problem of seizure is there. So
is it the seizure main
need to be
problem
controlled.
deciding? Is it the seizure?
Sir. No, sir. The baby is bedridden. We have to give a therapy for the patient, and also
So
other
what
than
is
therapy,
the
there are also
main
medical
point
treatment that is available.
which can catch you back? What is the main thing which is negative here? The intellectual problem.
Intellectual.
So whatever
Yes,
motor disability is there, if the baby is having a good intelligence part remaining, all the other things is still possible. Okay. So nothing will be possible when the association with this motor, the intellectual higher function part is child is not even recognizing the mother, and the assessment is less than 6 months.
Yes, sir.
And a 7-year-old child performing for a 3-4-month-old baby, the chances of your gaining the intelligence is too minimal, because your brain growth, whatever is possible, up to 2 years. Okay, beyond that, whatever good wiring and the improvement in the intellectual status is very, very unlikely. So the performance in that is for a less than 6-month-old baby. So that is the most important thing which catches you backwards. If the intelligence was good enough, all the other things, there are remedial measures. Okay. Okay. So your seizure, now the seizure is controlled with appropriate measures.
Yes, sir.
So seizure is not a problem.
Yes, sir.
Okay. So that is the main thing which catch you back. Okay. So what about the which you can do for the motor part, for the feeding part, your assessment of the different gross motor function part, your manual ability scale, you are assessed. Okay. So based on that, who all will be included as a team members in your management hereafter? Suppose the child is having good intelligence, who all will be calling you and getting involved here? And what things will you assign for them as a team leader?
Pediatrician should be there. Pediatric neurologist should be there.
Pediatrician as a pediatrician, what is your role?
We should have a pediatric neurologist that is present. We should have orthopedician to look after the contraction and the stiffness present.
What is your role as a pediatrician? You are the pediatrician. What are your roles? You are a team leader, of course, but what are where all you will be involving? You will be doing what all?
The general primarily all of the all other departments should be brought together by the pediatrician.
Okay. Your role only, apart from the team leading role, what all things will you take care of?
Take care of the general well-being of the child. Take care of the feeding difficulty part need to be addressed.
You may not be able to do it completely. You need the other people who are experts in that area. Okay, feeding part and the oromotor dysfunction part is a speciality which need to be involved. Then
Seizure control can be done, sir.
you can do the nutritional part.
Nutritional part can be
The
done.
respiratory aspiration, pneumonia, you need to treat micronutrient nutrient part, and on and off some other ailments are coming. Your role is there. So you are the one thing, you are one person need to follow up and subtle things like constipation, dietary advice, prevention of these things. Okay, urinary infections, hygiene, ear infections, dental caries, all these things are our own role. Okay, so you are coordinating with the other people, but you have a lot of things to do. You are the direct link with the parents. Okay, counseling with the parents and managing all these things. Okay, then who is the other person? You said, what is the role of the pediatric neurologist here?
To take care of the seizure part, sir.
Of course, right? Anything else?
If there is any behavior abnormality that developed, that need to be addressed, sir.
Okay, some other behavior problems, maybe
There
the
can
sleep
autistic
disturbances,
sleep
okay?
disturbances can
Sleep disturbances, the seizures, and what is the other major role for the neurologist here? What is the main problem here?
Cognition, sir. Intellectual.
Okay, that you cannot do much. What is the area where you can? The spasm, the motor problem, the spasm and the power. Okay, when there is a spasm, the power will be weak. There will be some weakness and the spasm will be there. So who can get involved? What are you going to do for the spasm?
Baclofen can be given, sir.
Drugs. There are a lot many drugs. It's not the baclofen only. The diazepam, baclofen, so the help can be sought for choosing how can you bring down the spasm. So what are the measures to bring down the spasm? One thing is medical. Okay. The logical use of the medications. Of course, you can get the help from the pediatric neurologist. Okay. What is the other mode where the pediatric neurologist is important when the spasm is not relieved? When the spasm is persisting, in spite of the medications.
Botulinum can be given.
Botox administration. There also you need the help for the
neurologist.
Okay, Botox. Where will be best working? Which situation it will be best working?
Dynamic contractions, sir.
You need to assess. You can also assess with the orthopedician to say, in a case of a position contraction, how much is the spasm contributed? How much is the fixed contraction? When there is a fixed deformity, it is the surgeon's role. When there is a spasm contributing, that is why R1 and R2 assess by the orthopedician. Or you can also do, you can decide there is role for the antispasm medications or bottles. Bottles can be used when there is a local selected areas, especially. Generalized spasm, it may not be that much useful, but in a diplegia case, or one side or one part only, the spasm is the Botox will work. So in this case, if the intelligence was normal and all, this is an ideal candidate for drugs followed by maybe Botox. Okay, so pediatric neurologist's role are there in different areas. So what about the physiatrist's role, physical medicine persons, maybe doctor or a physiatrist role, how we can help her?
There are multiple methods through which physiotherapy can be given. One is if the child is, if in case of hemiplegic child, we have to constrain that particular area and involve
in this case, there is no role for the constraint method. There are other methods also, habit method. Okay.
Habit method is there. And also for fine motor, we can promote a putting of the objects into the where coins can be put, sir. To improve the
fine motor. There are a lot of areas where the physiotherapy person can help. He can help in the, but always reducing the tone, improving the power and posture coordination. So physical medicine has got very high role, especially in the case of spastic CP, and very early involvement of the physiatrist is important. Okay, so I can decide about, with the help of the orthopedician also, the various orthosis, various things which are helpful in different areas. So foot angle orthosis, because different diplegic situations, I said jump gait, crouch gait and all. So there are a lot of things which they can help with an appropriate device selection. And who else can help you in the decision of this thing? Gait,
Physical medicine and rehabilitation.
physical medicine person in the advanced situations, there is another situation called the gait analysis. It may not be relevant for this patient, but in another situation, gait analysis. What are the methods of gait analysis and how can you get help? Gait analysis. Gait analysis. What are the methods of gait analysis?
There can be tiptoe walking because of the contraction that is present there in the sentence.
Okay, that's all just one of these things, tiptoe walking. Lot of things. Why you are assessing the gait? So what went wrong? What is the problem with the weight bearing? How the gravity and the weight is the position is affecting the other thing, joint, the transfer of the forces across the joints and bones, how it is impairing the normal movement and the deformities leading. So that is assessed by major two things: clinical assessment by your visual gait analysis, and the other one is a very costly thing. It's available in Bangalore, not here, by the camera, the digital methods. That's costly, but you can get an expert help from the visual gait analysis, and that's why you said the toe walking is the minimum what is possible. The other things are the crouch gait and the jump gait and all. By assessing the gait, you can decide what sort of a device, what sort of intervention is needed. So that is another very important persons to be involved in few of the cases. Orthopedician, and the next level of assessment. Orthopedic again is the gait analysis. Okay, you need to involve orthopedician. Will you involve in this your case? When will you involve the orthopedician? When will you involve the physiotherapist?
When the physiotherapy, when the contracture is becoming
not once it established, you are anticipating. So at the earliest moment, you are thinking that the baby is prone for this sort of a problem. You need to start your this thing, prevention of the spasticity leading down to deformity. That is where you keep the popliteal angle wider by keeping the pillow in between, the appropriate position of taking on the hip and the movement of the dorsiflexion of the foot and all. So you can start as a pediatrician, maybe you can involve them. The method of sleeping, how to keep the baby, what should be the position of the baby. All these things are early intervention, preventing the spasm. And that stage itself, the physiatrist help can be sought. It's not by the time it is already gone in for contractures. Okay. So in this case, what should be the assessment? How will you assess the patient? The motor part assessment should be by all the four assessment. Pull to sit, vertical suspension, ventral suspension, prone position. You need to assess. Here you said in the development, the five your assessment, the extension of the head was there. Actually, it's a little paradoxical, over-exaggerated assessment, because extensor spasm may be contributing that, and your assessment in the prone position may be overestimating that. If you are pulling to sit, there may be lag.
Lag was there, sir.
Maybe a little
Lag was there, sir.
Okay, so that is how you're, and flipping to 180 degrees though. So all these things are important to assess how much of spasm in different areas. In the vertical suspension, you know about the Elang sign and the scissoring sign. And the foot is touching. Though these are all early markers when you're putting the patient developmental age less than 6 months. Okay. And putting on the two only will be present. Okay, that is how you assess. And maybe it's not enough to assess in this position. You should be making the patient sit up, stand, and all these position also assessment is important. Then only you can say how much of this spasm is there, how much of deformity has already occurred. So assessment is very important because you are going to bring in different specialty people, and the group of specialty people we are involving are different in different cases. Okay, it's not multi-specialty people, all the 12 members need to be called. No. Depending upon your functional assessment, you invite all the team members for that. Okay. So in this case, basically, the involvement of the physiatrist is needed. Maybe orthopedician can be little later only. When will you do an intervention by the surgical team?
When the contracture is static, sir. When
static, and usually after the age of 7 or 8.
7 years.
Okay, not earlier. So the role of the surgeons are a little late, not now. According to you, there is no fixed contracture.
There is no fixed contracture.
There is
sir.
dynamic contracture.
Yes,
there is role for physiotherapist for angle or the devices.
Yes, sir.
And there is role for the medication. There is role for the botulinum, and surgery a little late only. So those are the team members to be involved. Okay, tell me how will you assess the involvement at different angles, different the foot, knee, and the hip. How will you assess?
We can see for the angles, sir. We can by using a goniometer.
Okay. What is the angle in this case?
In this case, adductor angle is around 40, sir.
So what is the cutoff?
Actually, it is present less than infants only. We have the cutoff, sir. We can use it.
Still, there is a scissoring is there in the vertical suspension, so it must be significant. And what you need to know is to palpate the tendon and see that it's tight. There's a need for, okay, maybe the stretching may not be enough. Okay, in that position, what is the most important prognostic situation? If there is a little bit of adduction, internal rotation, what will be what are you worried? About the hip.
Hip
all these
dislocation can happen.
Hip are very, very important because there is a migration index or something. When the hips are adducted and internally rotated in that position, orthopedician need to see the patient to assess, may not be intervening. Yes, sir, there are certain criteria. Where is the location of the head with the acetabulum? A migration index will be predicting the hip dislocation. So in this case, how can you ask the mother and find out there is a dislocation which has already happened? Which question will help you? Which question will help you? Question to the mother will help you that recently it has dislocated.
The spasticity has reduced.
The pain, extreme pain will be there. And one more thing, previously they were able to keep the pad, what is it? The paria?
Diaper, sir.
Diapers. So she's not able to keep the diapers recently. Till recently she was able to, but the diapers is not possible now and painful. So all these things are very important. One more very important thing is, never forget that the calcium, vitamin C deficiency can aggravate when you are manipulating, every chance that it can break. So these two micronutrient deficiency, you need to be careful. Okay. About the popliteal angle, there is very, very important thing. You need to assess about the contractures at that edge, and there are few tests. Few tests are mentioned for the assessment of these things. Orthopedician will be doing all these things, the abduction part and Thomas test. But about the fixed flexion contraction at the hip. And the rectus femoris and the contraction of the flexures, that also they will be testing in the prone position, doing these things. So orthopedicians are doing all these things to detect the shortening part. How much is the need for the intervention either by the botulinum or by the surgical release. They are assessing by different techniques. Thomas is one, Ellis test or something is there. And popliteal part, there are two things. How much is the contracture by the contributed by the gastrocnemius? How much by the soleus? How can you differentiate that? Gastrocnemius is crossing the knee. Soleus is not. So that again can be found out by the examination. Again, there is a method for that. You flex the hip 90 degree and then you assess. So that is the method. There are different methods for the assessment of this thing. Few of them are done by the orthopedician and they'll be deciding what sort of intervention is the time for the surgical intervention or. So in this situation for the management, you need to invite all these persons and you need to talk more about the interventions possible, botulinum toxins and all. The micronutrient deficiency, malnutrition, bronchopneumonia, all these things need to be managed. There is no bed sore, there is no callosity, nothing in this case.
Nothing, sir. No, sir.
So I think I'll wind up, I'll stop this patient. If there is any more comments from the experts, Srinivasan sir, Sushma madam, Bharati madam.
I have just now typed the comment in your this thing. We have extensively covered each and every angle of questions that will be posed by 4 examiners. Of course, usually external examiners will take it over. But anyhow, it was very enjoyable and I could see you in full form. Yeah, you brought out all the important areas which the student must be able to tell. And of course, usually I have seen in the course, they ask what are the poor prognostic factors in this child you are going to identify. And because we have to counsel the parents, otherwise they may not give proper regular physiotherapy, occupational therapy. They'll want immediate treatment. So what this thing, good points. Before telling poor prognostic points, we have to address what are the points which are favorable in improving the child's performance. These are 2 questions that will be usually asked in cerebral palsy. And of course, they want to give extra marks. They'll ask what are the various methodologies of physio and occupational therapy, various names. Of course, for giving extra marks and distinction. Yeah.
Thank you. That sir was highlighting that the Bobat technique, the oyster technique and all will be asked. And one last comment.
They're given textbooks, so they must know this thing. Because of course, that's not going to determine pass or fail, but that will determine extra marks and this thing, especially if you have gold medal or some other this thing, Yeah.
Last part, always never forget the social support. In the history, positively, you have mentioned about the social support. So you need to know about the rights of person with disability. What all are are they getting it? In our state, what all things are there? So suppose a disabled person is having good intelligence in a little bit older age group. You need to discuss about other things, about the educational thing. Okay. So very, very important. The planning, there is an involvement of another team member, not relevant here, the special educator. Okay. We need to involve sometimes the school teachers also. Okay. And a little older adolescent period, there are some other new problems which will be occurring in a disabled person in the adolescent period, like pseudo regression due to weight gain. They can have problems, superadded menstrual problems for a female with a disability. And the educational things, what sir was highlighting the positive things, how to bring them to the mainstream. What about the educational thing? Here again, you are trying to bring them as far as possible to the mainstream education. So what all adjustment need to be there in the school and educational institutions? As a pediatrician, we all have the responsibility to make changes in the society. How they are looking and what all facilities are there when you are building a room and a hospital, another institution, disabled friendly, it should be. In the society, what all things are disabled friendly. So we have a role for that also. Unless you know, you we make changes with the influencing the policymakers and other. So we have role. We need to know about that also. Not only merely medical treatment, institutional treatment. Don't restrict to this thing. You go out as a social person also. So it's very, very important when you talk about any of the disabilities. So thank you, Das. I am winding up. Thank you for the comments, positive comments from Srinivas.
No, thank you so much. Actually, I wanted to keep quiet, but you, because I am more of a listener than, yeah.
That's the point. Litika, I think we can wind up. That's enough.
Okay, sir. I think everybody enjoyed the discussion. It was a very fruitful discussion, though it was conducted in very short notice. I think Mohandas sir has a meeting today. Probably Sindhu has joined.
Hello.
Kekunundu, Sindhu.
Thank you all for participating in the discussion. So I think we'll find a session now. Okay, thank you.
Okay, thank you all. Good night.
Thank you,
Okay.
sir.